Good morning and warm welcome to everyone. I'm Prashant from Villa India. We are delighted to have you join us today for an insightful webinar titled Implementation of NNT Software in Endodontics Diagnosis. This session is hosted by Villa India in collaboration with Neotom, leaders in cone beam 3D imaging. Today we have the privilege of learning from Dr. Apurva Gupta, an esteemed expert in oral medicine and radiology. Dr. Gupta completed her MDS from Tirthankar Mahavir University and has significant experience across a variety of disciplines including radio diagnosis, forensic odontology, general medicine, ENT, and maxillofacial oncology. With an impressive portfolio of evaluating over 2,500 plus CBCT cases and contributing to numerous publications in her field, Dr. Gupta brings a wealth of knowledge and hands-on experience. This webinar will focus on the effective use of NNT software in enhancing diagnostic precision in endodontics, providing invaluable insights for participants and radiologists alike. So without further ado, let's welcome Dr. Apurva Gupta to take us through this engaging and informative session. Yeah, ma'am. Yeah, thank you.
Thank you, Villa India and Prashantji, for such a warm welcome. So today I am here for the presentation on the use of NNT, how we can enhance our daily routine practice by through CBCT. So let's start. So everyone is able to see the presentation now? Am I audible? Am I audible? Am I audible to everyone? Good morning, everyone. Okay, so let's start. We all know that the eye cannot see what the mind does not know. This is a famous proverb by Sir William Osler. So it holds a great message in CBCT. Let's see how. So this is the human body, and we can divide it into three planes. That is, first is the coronal plane, that is from the front to the back, or we can say from buccal to going towards palatal or lingual surface. Then we have the sagittal plane, that is the right to left or left to right, whatever it is, and transverse is from up to down. That is the axial plane we have. So here is the topic of my presentation today, implementation of NNT software in endodontic diagnosis, imaging beyond imagination. So let's see. So we all have the two-dimensional radiographs, or what we called as intraoral perioapical radiographs, in our routine practice in the clinics. So we determine the working length before going for the obturation and other procedures during the root canal treatment. So there are some limitations of the intraoral perioapical radiograph, or the OPGs we do. So first is the variable locations of the apical foramen. So apical foramen is not always located at the root terminus, and we see the different variations of around 3 mm in about 50 to 98% of the patients, what the study says. Next is, with the increasing age, there leads to the distance between the apical constriction of the root terminus increases with the increasing age. That is because of the increased deposition of the secondary cementum with age at the apex. So that is one of the problems that arises with the two-dimensional radiographs. The third is the variable anatomy of the apical constrictions. We all know there are 4 types of the apical constrictions. First is the type A, that is the most traditional one, the single apical constriction. The second is the type B one, that is the tapered constriction. Type C is multi-constricted, and type D is the parallel constriction. So the variable constrictions are not many times clearly visible in the two-dimensional radiographs. The next one is the two-dimensional images have less to no buccal-lingual perspective. We usually have the mesodistal perspectives in the two-dimensional radiographs, but not the buccolingual perspectives. The next one is the anatomical noise. That is the overlapping of the anatomical structures like the zygomatic arch. Especially this problem arises with the maxillary molars. And the last one is the geometrical distortion, that is the elongation and foreshortening of the images in the two-dimensional radiographs. So to limit all those limitations in the two-dimensional radiographs, we now have the cone beam computed tomography, that is the CBCT, what we call it as. It has become an indispensable in endodontic and endosurgical diagnostic treatments and control. And of course, it has become a real game changer. You can see a few cases here over the slide where we have located the unobturated canals or the fractures or the apical patencies very clearly through the CBCTs. Now the ALARA principle, that was the as low as reasonably achievable, that was for the radiation dose, is replaced with ALADA, that is ALADA, as low as diagnostically acceptable. It provides, the CBCT provides dimensionally accurate images with very less superimposition of the different anatomical structures, including the zygomatic arch. So we'll discuss the cases in detail later on. So first we'll go to the CBCT. So in the CBCT, there are different FOVs are there. So first one is the larger one that covers the entire craniofacial skeleton. The second is covers the maxillofacial, that is the maxilla and the mandible. The third is that covers the single arch, single quadrant, and the fourth one is that covers the single arch, that is the complete maxilla or the complete mandible. So in endodontics, we usually use the arch, the third FOVs, that is focused on the single arch because it gives high resolution images of the limited regions, and that is what we need in the endodontics. So NNT software, the Newton software, provides us with the different images of the we can extract the images, we can find out the different canals. So I'll demonstrate it to you. 1 minute. I'll share the slide. share करना है ये सॉफ्टवेयर को यहाँ पे. Just a second. Give me a second.
No issue, ma'am.
I'll share the software screen with the people so that they can understand very well. So, can you see the software here? The screen of the software here?
Yes, ma'am. Yes, ma'am.
Okay. So, this is one of the cases that I had opened. Okay. So, first of all, after opening any case, we go to the multiplanar section and make an arch form here. So here in this case, I had made an arch for the maxillary region, and here are the different cross sections that we are getting. On the lower right corner, you can see the different cross sections of the teeth are seen here. And as we are moving forward, the axial slices are also moving forward. And this is the 3D image. So in different cross sections we can see, we can enlarge it and see. So here in this particular radiograph, the tooth of interest was 2-7. So now we'll see that how we are going to locate the canals in the CBCT. So we'll go in the MPR section, locate the tooth in the axial slice. Okay. So now the axial section is little enlarged. You can see it clearly. You can see the 2-7. All of you, can you see the 2-7 here? See, I had located it.
Yes, ma'am.
This is the axial section of 2-7, or axial or the transverse section, anything you can say it. So now, can you see the 4 openings here? One is this one. I'm putting the cursor here, okay, or I'll put the arrow mark. That will be better. One is this one. One is this one. One is this. And one is this one. Can you all see these 4 radiolucid openings here on the axial section of 2-7?
Ma'am, 2 are very clear. 2 are not so much clear, ma'am.
I'll do it. Now, this one.
Yes, ma'am. Now it's okay.
And this one.
Yes, ma'am. Yes, ma'am.
Okay. Okay. So now we have to locate all these canals. Now we know that 2-7 are 4 canals. One will be mesiobuccal, one will be palatal, and in the distal root there are 2 canals. Now DD1 and DD2. This is now clear. So now we have to measure the complete length of the canals here. So how we will do it? We will change the axis. We will change the axis here, and now we will locate it in the coronal section or the sagittal sections. See. Now this case is little different, as in this particular tooth, mesiobuccal and the distrobuccal roots are fused together. So we have to see it in the sagittal section, and in the sagittal section you can see this is the root of 2-7. And here you can see 3 particular canals going from the coronal pulse chamber towards the root apex. One is this one is this one, and the third one is this one. This is a very faint line going here from here. I'll zoom it a little, then you'll find out. See, I'll locate it through the arrows. Are you able to see the screen?
Yes, ma'am. Yes, ma'am.
So one is this canal, the second one is this one, and the third one is this faint lining is there. So one is the mesiobuccal, the second one is the distrobuccal, and the third one will be the distrolingual. Then we will just confirm it by seeing in the axial section and the sagittal section. This one is the sagittal section, this one is the axial section. Likewise, we will locate the palatal canal as well. This is the palatal canal. So in this way, we locate the canals, different canals through CBCT. So in usual practice, we think that there are 3 canals in the molars, like mesiobuccal is there, distrobuccal is there, and the palatal. Sometimes we get MB2 as well. But in this particular tooth, we get mesiobuccal, and in distrobuccal root, we are getting the 2 particular canals, this DB1 and DB2. So in this way, this case came out to be something special one. Any doubts are there in this one?
Ma'am, can we change the contrast to improve the visibility? Like
Yes,
this one seems to be very faint.
Yes, we can change.
In endo cases,
We can change the contrast. 1 minute, I'll show you. Yes, we can change the contrast. Sorry?
Ma'am, usually in endo cases, it becomes little difficult when, canals are very thin and they're not, obvious. Like if they're not very broad, they're very, narrower canals. Like in this case, you were showing DB2, especially DB1 and DB2. They're very narrower as compared to the mesiobuccal and the palatal, which are easy to locate. So can we do something?
We can change the contrast. See, we can double click here. Wait.
Ma'am, I think the smaller FOV files would have given a better result. I think there's a medium FOV file.
Sorry, I didn't get your point.
No, this is actually I feel it's a medium FOV file. If it would have been a smaller FOV file, the scan would have been much more clear, I think, because Newton gives better scans.
Actually, the little problem with this scan is there. This is a full mouth case.
Yeah, that's
And for endodontics, we use the quadrant sections.
Yeah, the 5x5 or 4x4 would be great for this case.
Yes. But the contrast we can change from here.
Yeah.
Ma'am,
Yes,
does
we
it
just
the contrast in some
we
way?
just have to double click the image and change the contrast from here. Whatever suits us best.
Ma'am, in changing the contrast, like will help in, it will make our process bit easy in endo cases.
Yes, it happens. Especially changing the sharpness of the image. It helps. See, I'll show. Now I changed the little sharpness and you can see.
Even we can use the right side filters, gray color, blur color, and red colors.
Now the image is much better, I think than before, if you're able to see. Screen is visible now?
Yes, ma'am.
Yes. So now the images are better than before, I think.
Ma'am,
We
you
can
click.
locate the canals better than before.
Can you double click again, ma'am?
Yes.
Just try the right side filters below the cancel point. Sepia, blue film, red. Yeah. Maybe
So this also we can. But there are different filters. We have to use it according to, what is the best for us. Actually, in every case, we have to change it according to the case, according to the scan.
Yes, ma'am. So if we will apply on the Excel image, so.
But definitely improving the sharpness, changing the sharpness and the contrast of the image helps in locating the canals. Now the canals are much better seen than before. Like this. Can you appreciate now? Better than before?
Yes,
Yes,
ma'am.
ma'am, they're more clear than before.
Yes. So we can change the contrast, brightness, sharpness in every section. Even in particular scan, we can change it multiple times according to the image that we are seeing. We are locating it in transverse section, coronal section, axial section. We are extracting the NPR images, or we are extracting the cross sections. We have to change. If we are suspecting something, then we can change the contrast, we can change the sharpness, and then correlate with the things. So that is possible, and we have to do it every time. Any other doubts?
Ma'am, if it's possible, we can do the Bertuzzi's classification according to, the scans. We can predict like type 1, which type of canal it is, canal system.
Yes, we can do. We can do that as well. Like in this section, I can show you. One minute. This is the palatal canal that I had located here. Right? and this is one particular canal that is going from the occlusal tip to the apex. So this is what you see type 1. We will discuss different cases in further presentation. And for this one, for the distrobuccal and this mesiobuccal and distrobuccal, for the mesiobuccal route, again, it is what you see type 1 because one single canal is going from the occlusal tip, or you can see from here. This is the mesiobuccal route, this is the palatal route. So from the coronal pulse chamber till the apex, one single canal is going in the mesiobuccal route as well as in the palatal route. So it is vertice type 1 in each route, because the vertice classification we give in each route. And for the distrobuccal, first let me locate it. We can zoom in, zoom out according to our convenience. And this has to be done every time. So now the canals are located on that particular axis. And now we have to see it. So now, actually in this tooth, the two roots are fused, so it will be little difficult for the distrobuccal canal to check for the vertice classification. But if we see the distal end of this root, because this is the mesiobuccal root, these are the distrobuccal roots. One is the thin faint line and one is this one. So they are going from the coronal pulse chamber towards the apex, but one is going from here and one is going from here. And they are uniting together and exiting as a single canal. So it will be like 2, 1. That is what you see type 2. So in some tooths, sometimes it becomes difficult for the vertice classification. Then we have to go for other systems. But usually we give the vertice classification only. Because sometimes we get some complicated morphologies and for the root canals in some tooths. So at that time, either we just give that like 1 to 1 class is like this, or we go for other systems. But in general practice, we give vertice classification only. Okay, I have one more section, that is the quadrant one. So I'll show you that one. So I think the things will be much clearer. Wait, I'll open it. Give me a second. So this is one scan. Are you able to see my screen?
Yes, ma'am. Yes.
Yes. So first we will form the arch form. This is the way we we create an arch form using multi-planar window. We can crop the image according to our requirement. We can check the cross sections here. So now we get the cross sections. the different cross sections we get here. So you want me to trace the nerve here as well? Or should we skip that part and focus on the endodontics?
Kindly do the tracing as well.
Should I do the tracing as well?
Yes, ma'am.
Yes, ma'am, please.
Okay. So for the tracing, I'll change the thickness because that will be clearly visible then. See, now the nerve canal is like clearly visible. Can you all see? Even here we can
Yes,
change the
ma'am.
contrast and brightness of the image. So I'll do it a little bit. This is the bar for the canal. Then we will go it. This is the way we trace the canal. And now we can check if we have traced it correctly or not in the cross section. See. Can you see the red dot? It has completely overlapped the canal. That radiolucent round you can see.
Yes, ma'am.
Completely over that. The red dot. And that is our canal. That is our nerve. This way we trace the canal. Okay. So now we are done with the canal. So we'll change the thickness of the image. That also we can keep till 15. Depends on what we want exactly and how we want to deliver the images. So now for the endodiagnosis, because we are focusing on endodontics here, so we'll go in the NPR section. Here the tooth of interest is a minute, I'll check it. Here the tooth of interest is this one, 4-6. 4-6 is there. We have to see whether the obturation is done correctly or not. So first we will check in the axial section from the coronal till the apex will go. And we'll see if any canal is there that is left unobturated or anything else. So see. So now can you see one thing here in the distal root? This is the distal root of this particular tooth, 4-6. So after a certain point, till here the radiopacity is seen at 2 places here. After that, it is fainted out and then nothing is there. So now we get an idea that there is root patency here in this canal. Now we get this idea from the axial section. Now we will locate this canal. We will change the axis. We will locate it. And check it in other sections. See, can you see? this much part of the root is not obturated. And this is the reason of the periapical radiolucency here. We can also check it in the coronal section. Can you see this much part of the root is not obturated? There is no radiopacity seen in the canal here. We can measure it. It comes out to be around 3.3 mm, around 3 mm. So this way we trace the canals. Any doubt in this case? I think the images are also better than the previous section, the previous case.
Yes, ma'am.
Because this is the sectional scan, and that was the full scan. So for endo, we have to go for the sectional ones only, because we have to locate a particular tooth here. Full scans are better for the implants. Implant cases, full scans are better.
Yes, ma'am.
Any doubt in this case?
We can see that this tooth has got a crown. It's probably metal crown, TFM crown or whatever. So does beam hardening artifact has any role in this particular case in diagnosing, or it will not?
Beam hardening effect is there, especially in the teeth where crowns are placed, any prosthesis is placed. So we get some blackish lines, or sometimes it becomes difficult for us to, diagnose, especially if there is secondary caries is there. But, and sometimes even the radiopacities in the canals makes it difficult for us to, diagnose if there is any radiolucencies. But that happens because we have traced it in all the three sections. So in such cases, what I do specifically, I try to trace in all the three sections, like axial, coronal, and sagittal. If the finding comes in all the three sections, that means it is confirmed. And usually we see I try to locate the finding in at least 3 to 4 consecutive slices. If that is there, then the finding is definitely there. But sometimes when the canals are very much closer to each other, and in one particular section we can find we are finding that is not obturated, or any other finding is there, and in other section in coronal I find there is no obturation is there, no radiopacity in the canal is found. In sagittal it is there is some radiopacity. So in that case, beam hardening effect may be there. Particularly in the prosthesis cases where dental crowns are there, metallic crowns are there, it becomes difficult. But it depends on the clarity of the scan, the contrast and brightness we keep, and of course we have to correlate in all the three slices, in all the three sections. We have to locate it on the axial, coronal as well as sagittal. We have to confirm with all the three sections. And sometimes 3D images also help. Not in endo, but sometimes it helps in ruling out whether it is a beam hardening effect or something else is there.
And segmentation is, for segmentation we need to have some different software in case we want to apply to the MMT. Then segmentation is happening nowadays. We can just see only the canals separate. We can just delete all these surrounding areas of bone, and what we can get at the end is just the canals, That is called segmentation, if I'm right.
Yes.
But it's not possible with the MMT at this point. We have to, get the separate license for that.
Yes.
We can crop, ma'am. We can crop. This is this area, ma'am.
We can crop it, but what you are saying that only the canals we get, that is little difficult, because they will get the surrounding bone and the surrounding structures of teeth. But sometimes metal artifacts and beam hardening effects are, they are quite prevalent. So to some extent we can avoid them, but not completely. Otherwise, the X-ray exposures will be very high for the patients. So So that is also not acceptable. So I think researchers are going on in that field also, how we can lower down the effects.
We can apply the MAR filters, and second, we can use regular scan, not high resolution scans, for the remove metal artifacts.
Metal artifact reduction, that MR effect helps a lot in reducing all these types of artifacts. That is one thing we can do.
Yes, ma'am.
And it helps. MAR effect helps. In routine practice also, I also apply MAR effect. If very prevalent, these artifacts are there, metal artifacts are there.
Madam, is there any a tool in the app where we can come to know the volume of the pulp?
Volume can be measured, like we can measure the width, and not as such volume ka koi tool nahi hai, no tool is there. We can only do, that is also not very much possible,
We can measure only. We can measure only.
No,
We can't.
I understood. I understood we can measure it, but we can always measure in 2D directions only. We cannot have 3-dimensional volume, because a lot of studies are there where they demand, the PG students demand before and after, before biomechanical preparation and after biomechanical preparation, what is the change in the volume, which file system cuts the canal more. So there are a lot of queries about that in my institute. So I'm just curious if you have any tool where you can measure the volume of the pulp pre-operative, post-operative, like that. And what you do if you want to do that?
I think histologically that can be done.
Madam,
clinically it's little difficult. Even through CBCT it's little difficult.
Ma'am, it can be done, ma'am. Excuse me. Let me just say, it can be done. We can assess the volume with lot of this.
Yeah, with what exactly you're talking about?
You can try Romex. It's there. Many softwares are there. I think it's there in the NNT.
No.
I'm not wrong.
No, NNT I'm not able to find. I'm using NNT in my hospital, but I'm unable to find that. And there are a lot of queries from the postgraduate students regarding this, because there are a lot of cases going on the same subject. So, but we are unable. Then the way we are able to calculate the volume of the sleep apnea cases, oropharyngeal airspace, the similar way can we calculate the pulp volume, because for endo pulp is important. That's why.
But can we follow the same thing like what we're doing for the maxillary sinus, the way we calculate the volume for the sinus as well as the airway spaces? Will it be possible to apply to calculate the volume for the pulp chamber, pulp canal?
No, madam, that is not available. No, that is not available. That tool is not available in this.
For NNT it's not available. I guess it's only for the volume of the airway spaces we can do.
Only airway spaces. That is true. That is true.
All this is things are happening in recent cases where these things are very recent, when they're doing many things, with the pulp chamber, like you said, measuring the volume and, going into the details of everything, which is not possible with the present software the NNT is providing, I guess.
Okay, maybe that's the one query, because we have in my institute there are a lot of studies going on. They were curious whether if you can do this or not. I just wanted to know from the experts. Fine, not an issue.
As far as I am aware, the volume of the pulp chamber cannot be determined. Let's find out and let you all know.
Sure.
We can definitely measure the length of the canal. We can locate the canals. For the width, it's little difficult. We won't be able to do it accurately. So, yes, the length of the canals can be measured, and different things in endodontics we can diagnose.
Kindly throw some light regarding the fracture cases. They are very at times very difficult.
Yes, I'll be covering.
Okay.
Not every, okay. So can we continue?
Yeah.
Or is there any doubt in these things?
Ma'am, you can proceed further.
Yes, yes. Hmm. Hmm. Yeah. Share. Okay, so this is the vertex classification that we use. Type 1, type 2, type 3, 4, 5, 6, 7. So let's discuss some of the few of the cases I have extracted. So this is the case 1. The patient had complained with patient had come with a chief complaint of pain, and this is the basically a CBCT image only, but this is an OPG image that we had extracted through CBCT, and here we can only find that, I mean to say that this is a two-dimensional image, and there is an angular bone loss on the mesial aspect and the periapical radiolucency, what we are able to see. But through the CBCT scans, we can see in the distal root there was an apical. First thing is there is an apical root and curvature in the distal root is found. That is not clearly appreciated in the two-dimensional radiograph. We can see it to some extent, but not clearly appreciated. And then apical root patency was there in both the mesial as well as in the distal roots. Periapical radiolucency is there, involving even the furcation area. Then angular bone loss is there. Then on the distal aspect also we can see that some of the horizontal bone loss is there, and furcation in the furcation. And see, here, as we had used the Marr effect, to some extent we had reduced the beam hardening effect or the metal artifacts, we can say. So the next case is, this is a maxillary tooth, 1-7. In the two-dimensional radiograph, we can see a periapical radiolucency, but when we had done in the CBCT, and this is what we get, an apical root patency was there in the palatal root. So that comes out to be about 3.4 mm. So that was the reason of pain for the patient. So that is not clearly appreciable through the two-dimensional radiograph. So next case is, this is again a maxillary tooth with the chief complaint of pain, and the periapical radiolucency is what we can see in the two-dimensional radiograph. Through the CBCT sections, different CBCT sections are there. The mesiobuccal root is there, distobuccal and the palatal root. So we can find clearly that there was an apical root and patency in the mesiobuccal and the distobuccal root. Then in the palatal root, you can see that approximately 3.8 mm, what we are able to find here, approximately this much part of the radiopaque material was seen extruded from the apical root end of the palatal root. And also to some extent there was a resorption of the root end of the palatal root was to be seen. And periradicular radiolucency was there that has extended upwards till the furcation region in the palatal root. So that is the beauty of CBCT, that we were not able to clearly find out in the two-dimensional radiograph the extent of the radiolucency. That is clearly seen in the CBCT radiograph. Then this one is again mandibular tooth, 3-6. The patient had come with a chief complaint of pain. Here we can see, we can measure. This is I think the granuloma is there. We can measure it. We can measure the extent of the radiolucency on the mesial root as well as on the distal root. And we can also see some hypodensity or a void was there between, I had already marked it, between the radio opacity and the width of the pulse chamber. So that may be one of the reasons why the patient was having pain and the periapical radiolucency. Because if we see the crown, that was almost appropriate. We can't see any secondary, caries or any fracture type of thing in the crown area. But when we see the canals, so this hypodensity may be one of the reasons why the radiolucency was there. Periapical radiolucency was there. So next case is of a mandibular molar. This particular tooth has dental caries over it, and the apical root and the resorption was there in the mesial root, and unobturated distrobuccal root canal was found out. See, this is the unobturated distrobuccal root canal was there. We had located it, and the apical root resorption. See, this is the root resorption we can locate in the mesial root. So distal overall prevalence of the distolingual root canal in the mandibular first molar especially, that is around 22% in that, and ranging from 3 to 50%. So what I want to explain through this particular case is, when we see two-dimensional radiograph, we were not able to find out that there was an unobturated root canal in the distal root. But through the CBCT, we were clearly able to find out that distrobuccal root canal was not obturated, and that was the main reason for the periapical radiolucencies as well as the pain for the patient. So in this case, two teeth are there, 3-6 and 3-7. The patient had come with a chief complaint in this region, in this particular region. And the IOPA findings, actually, I had a call with the doctor, with the referred doctor, and he said that he is suspecting some trauma or any deviated anatomy in the distal root of 3-6. So when we had done the CBCT scan, we found out that it is a case of entomolaris. So there was an extra distal root, or the distolingual root was there in the 3-6. And in 3-7, there was an extruded endodontic material. This radiopacity was little extruded in the mesial as well as the distal root. So this was the reason of the pain for the patient. And also in the IOPAs, we found out that there was PDL widening was there. Little PDL widening we can appreciate on the apical root end of the mesial root. But in the CBCT sections, we can clearly see that the PDL widening was there in both the mesial as well as on the distal roots. So for radix entomolaris, there is some additional information like overall prevalence is 3%, that is ranging from 0 to 12%. And in India, the highest prevalence is in North India with about 24%. And in the world, the highest prevalence is in China, that is 32%, and minimum is in Africa, that is around 0%. So this is the case of canine, a maxillary canine. So in two-dimensional radiograph, through this one radiograph, we can see that there is an apical root patency in the lower third of the root canal. Clearly we can see it. Through the CBCT, we found out that there was, apart from the apical root and patency and the periapical radiolucency, there was one unobturated root canal, that is the palatal root canal in the maxillary canine. So the percentage of permanent maxillary canines with this type of root configuration is around 4.35%, type 3, and for the type 5 it is around 2.17%. So this is the type 3 root canal morphology that we have found out, and it is its prevalence is around 4.35%. So this is just I had put because this is a mandibular canine with two different roots and two different root canals. So the global prevalence of two roots with two root canals is around 7.5%, and the global prevalence of two root morphology for the mandibular canines is 1.9%. And in Saudi Arabian population, the two-rooted mandibular canines is 0.2%, and two canals is 4.6%. So this is a case of mandibular canine. So these are the different images for the fracture line that someone was asking for. So patient had complained there is some pain in this region. So I had extracted some of the CBCT images here. This is for 2.6. So we can see a radiolucent line here. So for fracture lines also, we have to correlate in all the three sections. Like we have to check the axial as well as the coronal and the sagittal as well. Only then we can confirm it that it is a fracture line, because many a times artifacts are also there, or maybe it is something else. So if we are able to correlate in all the three sections, then definitely it is a fracture line. So here in this root, we can find out a fracture line is there in the distrobuccal root. Then from the occlusal surface till the coronal pulse chamber, again a fracture line was there, again a radiolucent line is there. Then sinus floor obliteration or communication between the root and the sinus is also there in the distrobuccal root. And this is the palatal root. In the palatal root also, we are able to find out a fracture line from the occlusal surface till the coronal pulse chamber. And also a buccal cortical plate perforation is there in the palatal root end. And perioapical radiolucency is also there. And here I had measured the root canals, working root canal, radiographic working root canal length from the occlusal surface till the radiographic apex. So these are the different. So this is how we give the Bertuzzi classification. So it is like 1, 2, and 1. So this is Bertuzzi type 3 for mesiobuccal root. And for the distrobuccal and the palatal root, it is a single root canal. So we give it as Bertuzzi type 1. So this is how the fracture cases goes. Then again, this is a fracture of maxillary anterior teeth. So we have 3 teeth here, 1, 1, 2, 1, and 2, 2. So patient also obviously had a history of trauma. So we were able to find out the fracture line at the root apex. It is the fracture line is going from the root apex till the nasal floor. Then pedial widening is there on both the labial as well as the palatal surface. This is for 1, 1. And Bertuzzi type 1 is there. I have not measured the root canal length here, but if the case requires, we have to give the root canal length as well. This is 2, 1. So there is some cortical plate perforation is also there in this, apart from the pedial widening and perioapical radiolucency. And one fracture lining is also there. A very thin radiolucent line we can appreciate here from the root apex till the nasal floor. And this is the lateral incisor, 2, 2. Pedial widening is there, obviously. Cortical plate perforation on labial aspect is also there. And there is some deviation in the tooth. So this is a luxation injury, and when we had checked for the occlusion through the radiograph, so it found out that the incisor edge were a little apical to coronal to the other teeth. So it must be a luxation injury or the extrusion injury for this particular tooth. So perioapical radiolucency is there, widening is there, cortical plate perforation on the labial aspect as well. And these all things were there for these anterior teeth. Okay, so this is how we give the Bertuzzi classification. This case is I had put here to show how we give the Bertuzzi classification, because in the IOPA or in the basically two-dimensional radiograph for this mandibular molar, there was a pedial widening was there on the mesial aspect, and the patient had apical periodontitis. So after extracting the images, there were on the mesial root there was Bertuzzi type 2, and we had measured all the two root canals, the mesiobuccal as well as the mesiolingual root canal, and for the distal root as well, we measured the canals. the CBCT is also helpful for third molar endodontics. Sometimes patient requires there is a requirement for the third molar endodontics, so mesial root as well as the distal roots. We have measured the root canal length for the mesial as well as the distal roots for third molars. Okay, so what are the different applications of CBCT in endodontics? So we are able to identify the root canal system anomalies. If there are any anomaly, like if there is any deviation in the Bertuzzi classifications, like we are not getting like we had seen one case in maxillary canine. So usually we get Bertuzzi type 1 in maxillary canines, but there was a deviation there. So if there is any root canal system anomaly, so CBCT is best for identifying all those things, determining the root curvatures. If there is any dilacerated root, so we can go till the radiographic effects through the CBCT. Then diagnosing periapical pathosis in patients with no specific clinical signs or symptoms, poorly localized symptoms associated with an untreated or previously endodontically treated tooth. Then we can diagnose the periapical pathosis in patients that are not clear in conventional imaging in the two-dimensional images. Then diagnosing the periapical pathosis in cases where anatomic superimposition of roots or areas of maxillofacial skeleton is required to perform the procedures. Then diagnosing pathosis of non-endodontic origin to determine the extent of lesion and its effects on the surrounding structures. And diagnosing the dentoalveolar trauma. We had seen a few cases. Because of little lag of time also, I won't be able to show all the cases and how we trace them in the software. Then assessing the endodontic treatment complications and localizing root resorption. We have seen a few cases here of root resorption as well, and any pre-surgical case planning. Then a new concept of guided endodontics has arrived recently. Then guided orthogate procedures are based on the CBCT data, includes precise planning and fabricating suitable drilling template, helps in determining the accurate depth and direction of excess cavity and the root canal, and it also helps in avoiding surgical intervention by precisely locating the obliterated canal systems in deep root areas. Some of the disadvantages of guided endodontics is the increased cost, obviously, more time consumption because a splint has to be fabricated here, and the increased radiation exposure. So these are some of the advantages of the CBCT scans. First is the rapid scan time, then beam limitation is there, image accuracy, reduce patient radiation dose. It demonstrates the features, and we get apart from the MPR images, we also get the 3D images here. So that is one of the advantage of CBCT scan, multi-planar reformatted images, including oblique curved planar reformation, serial transplanar reformation, ray sum or ray casting, increasing the number of boxes, helping in thickening of the multi-planar images. Then 3D volume rendering, that is visualizing the 3D data through integrating larger volumes of the adjacent boxes. Then this is a table showing the differences between the panoramic as well as the cone beam computed tomographic scans. The first is the set technique factors. Some of the similarities are there and some of the differences are there. So I'll read out only the differences. The differences for CBCT is that the CBCT offers more choices than the panoramic radiograph, which usually has only KVP. Scan factors for CBCT should be adjusted to be task specific. Then prepare the patient. Patient may also be supine and no bite block is used for CBCT. And left torso shield or thyroid shield is desirable for the CBCT scans. The scan time varies from 5 seconds to greater than 30 seconds. The motion artifacts are more likely to occur. Frequent image calibrations are necessary. Then to view the image must be reconstructed before viewing. The secondary orthogonal images must be reformatted. So these are some of the similarities or differences for CBCT between OPGs and the CBCT. Then exposure time. So the hospital CT has usually 0.6 sieverts for both the jaws, while the CBCT for both the jaws has an exposure of only 0.068 millisieverts. So that is very less, and that's why we prefer CBCT scans over the hospital CT scans. These are some of the limitations of CBCT. because obviously good things come with some limitations as well. So we have artifacts. These are the X-ray beam artifacts. Patient-related artifacts may be there because patient may move or any other thing may be there with the patient. Scanner-related artifacts, cone beam-related artifacts, that includes partial volume averaging, undersampling, cone beam effects, and image noise or poor soft tissue contrast. Okay, so this was the end of my presentation. So I would like to express my heartfelt gratitude to the very supporting team of Newtom and the Villa India. The Newtom has created the first dental CBCT machine we all know, and we are relying on that on our routine dental practice nowadays, and it will be good if we do the CBCT scans before our clinical cases, because it helps a lot and in diagnosing as well as in the treatment plans, in deciding the treatment plans for the patients. Okay. Thank you. Thank you so much.
Thanks to ma'am for sharing her valuable insights on the implementation of NNT software in endodontics diagnosis. Your expertise and experience in oral maxillofacial radiology have been truly enlightening. A special thanks to all the participants for joining us and making this session interactive and engaging. We look forward to hosting more such informative sessions in the future. Warm regards, Prashant from Villa India. Yeah, thank you. Thank you so much. Thank you to all.
Thank you all for such an insightful session. I hope you all had something to learn.
Very insightful lecture, ma'am. And really, I learned a lot from your cases, and many more I am expecting from you to conduct these kind of presentations, so we can incorporate in our clinical expertise. Thank you so much, ma'am.
Thank you so much. Going. Negative. Take a screenshot of it. End the meeting, sir.